Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD's CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Dr. Emily Weber. Dr. Weber is the CMIO at Indiana University Health and Riley Children's Health. She is a 2024 HIMSS Changemaker recipient as one of the most influential women in health IT today. She is an innovative and tenacious physician leader, clinical informatician, and pediatrician. Dr. Weber, Emily, welcome to the show.
Thank you so much for having me and for that very generous introduction, Alan. Appreciate it.
Well, we appreciate you coming on the show today. You know, your career is really a testament to your commitment to transforming healthcare through innovation, with a real particular focus on being with the patient and truly listening to them. So I want to start kind of back at the foundations in the beginning. What inspired you to pursue medicine and pediatrics as your initial path into making a difference?
Yeah, that's a great question to start off. It's actually great and auspicious because my medical school is having their white coat ceremony this week. And so 24 years ago, I got my short white coat here in Indianapolis. And at that time, I think if you'd asked me 2.5 decades ago, it was always clear, even if I maybe didn't articulate it, that I wanted a career that was about connecting with patients and connecting with their community and their needs. I would say very openly, I don't think at that time I said, and the way I'll do that is working in the EHR and working on technology. It was just very much foundational to the way I felt like I could contribute. And so I trained at the medical school, IU Medical School here in Indianapolis, and my residency training in Los Angeles just kind of reinforced that. And I trained in like a HIMSS level 7 fully wired pediatric hospital, Children's Los Angeles, which I love being part of that organization and learning. But it's very different than learning to be a doctor on paper. Yeah. And so then when I started my work as a hospitalist at Riley Children's Health, where I still practice, we had some opportunities. That's what we say, right? We had an opportunity to kind of leverage some of those. And that's really kind of where things took off. I work as a hospitalist, and when I was hired, one of my mentors said to me, like, your job is to be the connection for this patient, for this family, for their doctor back home. And they'll remember that. He always said that, and I still take it very much to heart. That is a huge honor and responsibility to be that person in that patient's life. And so that's where it took off. I worked on, cut my teeth in the trenches implementing EHRs like a lot of us did. And then over time, especially in the last couple of years, the opportunities that have emerged out of healthcare really has to change. If it wasn't the demands of, resources and finances, our patients demanded and their lives demanded. And so even though I work in a hospital and I love that work, my attention is often thinking about what happens outside of the walls of our clinics and hospitals. And like you said, that idea of listening for patients' needs, listening and meeting them where they are, that's just a really common theme. I will always probably return to the patient's perspective because I think that will tell us the way to be successful. And they'll certainly tell us if we're not being successful. Mm-hmm. So that's still my work. And here at IU Health, I'm really thrilled because that's taken me all over the state. We're the largest provider here, and then beyond as well, into our benches and our research mission, into the big data sets of the Indiana University, our partnerships with them and with Regenstrief. And it's just been an incredible, it's really just wide open for clinicians that want to have a role in this. So that's been a thrill.
Amazing. What's fascinating is that your philosophy on making listening to patients a huge part of how we do care, I think often doesn't lead to folks going into technology and IT, because a lot of clinicians feel that technology has created a barrier in some ways between the clinician and the patient. So curious to know, when were you first bit by the tech or informatics bug, and how has that grown since?
That's a great question. I think I have a very vivid memory of trying to spell an antibiotic correctly when I had to use paper orders. And I remember I went down to our then chief medical officer's office. It was like my first week. And he said he had an open door policy. So I assumed I meant I could just walk in and tell him what I thought. And to his credit, he always welcomed that. And I said, I really think we could use this differently. And it could help with keeping our patients safer. And then the nurses could read my handwriting. And that was literally the first week I was a pediatric hospitalist. Wow. And I did love that part of it. But I think you're exactly right that it very quickly it's like that line from Jurassic Park about just because you could didn't mean that you should. That idea that like you can digitize a lot of things. But I think in terms of listening, like the patient will tell you if that's valuable to them and if it's what they need. They'll also, sometimes we have not just our patients, but my fellow clinicians say to me very vividly, I remember we were working on the things that are always intriguing, like, oh, we could make an alert for, we could do a powered, an order set for, or let's tweak this within the EHR. And early on, when we were looking at some of those elements, a doctor said to me, she said, you're solving problems I don't care about. This is a problem I don't have. I think that is what became clear as I worked through a lot of physicians like myself. And as you work in healthcare technology projects, I think early on it was a little spaghetti against the wall. It was, oh, we can do all this. This is so exciting because you can really change this tool that I use every day in care. And then pretty quickly you realize just because you can doesn't mean that you should. And the people that are going to tell you whether it's a useful change, they're your patients and they're your teammates or your peers in my case. And I think that's been a really important skill for a lot of us in health technology is being humble enough to say like, okay, I have some skills, but you've got to tell me if this is making your life easier, if this is improving the care of your patients. And then I'll add on one more idea. Sometimes and I'm a pediatric hospital, so in some ways I love the immediacy of my work, but I'm in the long game. I'm trying to make healthy adults, right? So we're not always the most patient to say like, just because it's not valuable in this moment, in the next 30 days, is it delivering value that we can afford to kind of see in the coming year or even years? I think that's a big challenge because you've got the digital world who is used to doing entrepreneurial startup space speed, and then you've got the healthcare world where I don't think we're known in healthcare for being wildly fast at adopting new things. I'm a little hyperbole there, but the clash of those two has just really, I think that's certainly been an area that I've found very intriguing and has kept me, that gets me up in the morning every day because I'm like, here are these two incredible cultures with so much to learn from each other. What a gift to get to work in between them sometimes, but hopefully together.
Today's episode is brought to you by DeepScribe, AI clinical documentation that physicians and health systems love, documenting specialty and complex care with ease and precision. Josh, have you heard all the buzz around ambient AI and virtual scribes?
Definitely. Clinicians are spending hours a day on documentation, so improving their day-to-day and reducing burnout is huge right now. You know, you and I have seen quite a few product demos for ambient this year, but I have to say, DeepScribe was one of the most impressive.
Well, Josh, you trained as a clinician. What stood out to you most about DeepScribe?
Well, using AI to transcribe and summarize the clinician-patient conversation is honestly table stakes right now. But a big challenge for CMIOs and CIOs is driving actual clinician adoption. So what really impressed me about DeepScribe is how well it can be customized to different specialties and workflows with dozens of templates as starting points. You know, that would be critical to me as a clinician because I just don't have time to build templates from scratch.
So true. For me, I was particularly impressed by the auditable notes. You can highlight any part of a note, and then DeepScribe shows you exactly where in the transcript the note was generated from. So you can find that evidence right away. That builds trust.
Oh, exactly. You know, being able to confirm that something wasn't hallucinated is so important for clinician trust and safety.
Yeah, that same attention to detail that led to really high clinician adoption is also resulting with clinicians saving up to 75% of documentation time.
Wow, that's incredible. But how is DeepScribe's accuracy with specialty care or complex cases?
That's the best part. DeepScribe's proprietary LLM, Heal AI, is trained on over 3 million patient conversations. It's then further tuned by specialty and subspecialty cases, making it way more accurate than GPT-4-based solutions. Pair that accuracy with DeepScribe's customization studio to personalize the experience for different clinician preferences and workflows, and it becomes incredibly flexible.
You know, Alan, speaking of flexibility, I could use some yoga myself. Flexibility is key when it comes to working with health systems with so many moving parts. DeepScribe sounds fantastic. Where can health systems learn more?
About your yoga? I don't think they want to. But about DeepScribe, check out deepscribe.ai. That's deepscribe.ai to learn more.
So many interesting things to unpack there. One idea you brought up was the concept of, you know, just because you can change or do something doesn't mean you should. And I think that's really relevant with the growth of AI over the last year or two. And so I'm sure as a CMIO, there's all kinds of use cases being thrown at you around, hey, we should do this or do that with AI. again, to your point, just because you can doesn't mean you should. Curious to know from your perspective right now, what's sort of the highest ROI, low-hanging fruit use case for AI that you think should be focused on in healthcare? And then maybe are there a couple that have come up where you're like, just because we can doesn't mean we should.
No, completely. And we a few years ago, before, I'm going to say before, and it was before the kind of the big explosion with chat, we had this, very glamorous committee. And so we had this governance group because we said, at minimum, we need to understand the risk of these tools. We just need to say that we've reviewed it, and we have to have a way to assure our patients and the public that we're being responsible with their data. So in that is where we've seen the majority of those use cases come through. And you're exactly right. I think most clinicians and health systems are under so much pressure to produce faster and at unprecedented acuity. And also, oh, please do it, be budget neutral, make it even cost less. Like there's this pressure that is helpful in driving change, but it also makes people maybe a little too willing to accept risk, and maybe risk we're not even aware of. So one I'll call out is kind of maybe bias that exists inherently in every data set. When we talk with people wanting to use these tools, they say, oh, this is not a biased data set. They are not a biased tool. They are very committed to being equitable and accessible. Then we say, well, what data set is it trained on? And we're not, to say something's not biased is concerning, right? So I think that that's a good category, because that means that the things that seem like no-brainers, like the automation of things that we all don't feel are adding value, so prior authorizations or payer approvals, or even some of the nuts and bolts of running a large group of your HR tools, for example. Even those places where it seems like I always talk about it as like further from the patient. The sharp edge of this tool is not impacting directly patient care. Even those, you need to ask those questions. And I think that probably the biggest immediate values in those automation steps, and it's not saying don't do it. It's just saying do it, but know that you are, you know what you're doing and the risk you're incurring. And then also the dependency you're incurring, right? Like if you look at the upside downside of being so connected with everyone is something like the Change Healthcare situation. What is your plan for when you don't have that tool? And the plan might be, you know what, AI fills a niche that we can't do a manual downtime. And that's a new idea, I think, for us in healthcare, that there's just some things that won't happen if we have these tools. So I think I realize that was a little broad in what I'm saying, but I think everyone wants to rush to that, let this help the patient directly use of AI. And I think there's use for that, but I think there's probably more certainty and more confidence that we're not going to first do no harm if we are looking at some of those processes that are kind of augmenting the work of healthcare a few steps removed. But it's a pretty short journey to the patient in healthcare, right? It's only a couple steps. If you take an HR tool that pre-screens your applicants, suddenly your workforce might not be reflecting the patient you serve. Like it's a pretty short journey. So I might be called the Debbie Downer in our governance committee. I'm frequently saying, maybe I've just seen too many movies of AI run amok. But at HIMSS this year, there was a great speaker about like the great hope we still have in the AI, even though there's more movies about it becoming aware and sending us into a post-apocalyptic problem. There's still great hope there, and that's, I think, what our charge is as leaders in this space. So,
to your point, it reminds me, you've seen these presentations all the time at HIMSS or health or whatnot, where folks will say, hey, like digital and AI are transforming, retail and banking and all these other aspects of the consumer experience, and then it has to change healthcare, et cetera, et cetera. But to your point, that's an easy concept to talk about when we're thinking about, let's say, the administrative or the payment or whatnot aspects of the consumer patient journey. But when we get into actual clinical care, where, it's not okay if there's a mistake in, a direct clinical care interaction with the patient, that's not the same as making a mistake in retail, right? So the bar is much higher during direct patient care. And so we have to remind ourselves of that. So to your point, great, maybe we can accelerate AI for the back office admin stuff, but direct clinical care, it's like, okay, we kind of have to be more thoughtful about this,
The other part of this too is this idea. This is a newer idea to me and something we're doing here at my organization, this idea of a more product mindset versus from like a more transactional mindset, this ongoing idea that we have not just a transactional yes, no. I realize I'm now gesturing with my hands on an audible podcast, which is not going to help you. But, as you think of, I think it's a big shift for us in healthcare. Like we are, we're scientists. We like to know where the data is coming from. We like for things to be clear, for it to be black and white. But it takes some time. Like this is really like I think that idea, the way we consider these tools is probably foundationally more about how we'll transform as healthcare than the tools themselves. I mean, no offense to our colleagues and our fellow developers, but I think that will be what's kind of the product may change, the interface may change, the visual may change, but the way we look at this and the way that we approach problems for our patients and healthcare crises, I think will be, I hope that again, I'll go back to the hope there, that's the thing that gets me excited here too, is kind of that opportunity to be part of that, to have, I mean, that sounds so long ago, to 20 years ago to have gotten my short white coat. There were no cell phone, there were smartphones. I said that to my kids and they were like, what even is that? Like they could not comprehend, because it's so integral to get to train and practice and live and be part of our community during this change. If it feels crazy, it's probably because it is. And that's okay.
Do you still have a landline in your home? Like, have your kids seen a landline?
Okay, there is a landline. There is a landline, but it is because we had it for something. We had it for something that needed a landline. I don't remember now what it was. And but they're like, they think it's like the funny phone that like sometimes gets called, like auto called, and they're like, well, you never answer it. Like, why do we have this? I'm like, that's an excellent question.
Have your kids ever seen a payphone?
So we saw one. Okay, so we went to New York City on a trip, and in a museum with a set from a play, there was a payphone, and they're like, "What is?" I'm like, "That's that's a landline." They were like, "What? How do you know the number?" They asked all these, and I'm like, "Yes, these are things that are just not native to those following behind."
That's so funny.
Wait until they find out about the fax machine and how many faxes we're still sending.
I know. Well, and I think like, periodically when you are experiencing healthcare with a family member or someone who doesn't work in healthcare and they see the fax machine, like a fax number, really, who has what, and I can almost see their faces changing as they're like, oh my goodness, I am giving my life and literally my life over to this, to healthcare that uses a fax machine. So, but that one's a hard one to prune. Still present.
Right. So, Emily, I want to take a step back. Earlier in the conversation, you were alluding to this idea that you sat right in the middle between these two different worlds. And one of the key components to your success has always been listening. And so I know in some of the research that we did, we came across the story of your red shoe pin. And so I'm curious, one, are you still wearing that pin today?
Here's my badge. I had to go look for my badge. I got to check my badge, make sure it didn't fall off. Yes.
That's great.
Yes,
so
sure.
I think the red shoe pin just beautifully illustrates the importance of listening in healthcare, listening to the patient, and in your case today, listening to your peers as well. I'm curious how that skill, how you go about cultivating that, and moreover, why prioritizing the skill of listening to all of the stakeholders involved in whatever initiative you're working on. How does that inform the way that you go about navigating the complexities of healthcare IT?
Yeah, thank you for bringing that up. I love to talk about that Red Rouge Award. It's something that Riley Children's Health has done for years, and it's named in honor of a patient, a little girl who wore her red shoes every time she came to the hospital and every time she went to a procedure. And it's so meaningful because it is something that our patients actually and their families can nominate you for. And now my husband and family might laugh at me a little bit because they're like, really? You think you're a good listener? So I'm constantly humbled by the chance to improve my listening skills. But the reason I love it is because it's something we can all do. That's one thing. But the other thing is that we are all under so much pressure for our time, our most valuable resource, that on average in healthcare, even though we can develop as listening, it feels like this luxury. There are great statistics in the literature about how long a doctor lets a patient speak, air quotes there, lets a patient speak before we interrupt them. And there's several papers about it, but it's an incredibly short period of time. And it's about, I think at its heart, listening is also about allowing the control to be shared in the conversation and in what you're doing, because we always said too, the patient will tell you what's wrong if you give them enough time. And there's even the doorknob phenomenon of, here's the thing I didn't say yet, when you get up to leave the room in the shared space where you are. So I always remember that red shoes pin. And because of the family calling out that it wasn't a complex or a heroic thing that they wanted to call out. It was literally just making time to listen. I remember when it happened too, because I was like, what is, because I was thinking about the patient. I was like, I didn't really do any. I was saying this to my care Alex. I was like, oh, guys, I don't really do anything. Are we sure this is the right doctor? Like, did they want to recognize someone else? And they said, no, don't you remember that was that night? And I think someone may have even said, it took you forever to get out of the room because you guys talked a long time. And it's a good reminder that is, for all the demands that we all have on all of our time, you will never regret the time you spent doing that very passive skill. And, whether it's American competitiveness or whatever it is that drives us to be talking and filling the space, it's something I always am still working on. I realize even in the course of our conversation, I'm talking very fast and I'm filling this space with words because you are all so much fun and interesting to talk to. But it's a practice anyone can cultivate. And it's one of the most powerful things that we truly do, and not just waiting for someone to stop talking to then voice your incredible insights. There's so many smart people in technology and healthcare. It's almost like we're stumbling over each other to share, which is wonderful, but we got to balance it with hearing and listening too.
Can I ask you, like, what you think are the best ways to improve that, like, importance of listening in the culture of delivering care? Because I can only imagine, like, as a trainee, you tend to kind of mimic your mentors, your preceptors over the years. So if your preceptors don't prioritize communication and listening, you pick up on that and you assume, oh, that's the way I should be as a practicing clinician. So short of training everyone to do this better, have you found anything to work in terms of how do you get that message spread across, a large group of stakeholders?
Yeah, that's a great question. Hold on, let me put it in Chat GPT. I'm just kidding. I'm just kidding. I was just thinking about ambient listening, Joshua, and like how much insight we're gaining from that. I think I actually benefited from great mentors who did this so well. And what you started to see was, you saw the trust that built. I'm a hospitalist. A lot of times people have never met me. They might not meet me again. I have a very small window to establish trust. So there is that observation, like you said. It's almost counterintuitive to the things we reward in healthcare, right? Like, get this data, get them to answer the questions, get your patient to answer this, answer that. So I think we partly have to demonstrate that it's valuable. I hate to, it's such a boring answer to say, like, we should study it and demonstrate that it improves trust. But those have been done. The studies where they examine if the physician sits down. And we actually had a couple QI efforts where we started simply putting chairs in the emergency room spaces so that the physician can actually sit down and then be intentional in the moment. So I think there's pragmatic interventions to demonstrate and reinforce the behaviors we want to see, right? Like some classic QI, you slip that in there, that can be effective. But I think the other part is we probably have to go one step back and start cultivating that's a valuable skill and building that into things like the structures of the way we structure appointments, the way we have to build those in. And in some ways, like the advent of that ambient listening piece, I think is going to be really key to that. And this is not one that's always called out. Like, we still talk about how much time we save the doctors, et cetera, et cetera. All of that is great. I'd love to continue to see come out of that particular technology. And you're seeing some of this now, but like, how does that make the patient feel? How does it correlate with their experience? How does that, the fact that something else can be pulling down what we need for the legal EHR, does that translate into me being able to focus on you and your family and observe things that I would miss otherwise? Nonverbal cues from your mom or the parent or the sib or or my fellow colleague in the room who makes a face when they say one thing or the other. I think that how we listen, as that is one of my great touchstones of what I hope we'll see, is that a return to that undercultivated skill and valuing it, and not only valuing it, but putting some meat behind giving people time to do that in encounters and visits. So that's kind of a roundabout answer to your question, Joshua, but those are my ideas. It's hard to do it alone because we're not rewarding it. We're rewarding faster, shorter, and we want to save times and efficiencies. But we also, I do think consistently to our trainees, we talk about when you're in the moments when you're giving like life-changing news or bad news, and that's different for every patient. They talk about not talking. And we try to say, if you've said something like a new diagnosis, stop talking. Just stop. And we're so eager to fill that in and reassure and things. It's so hard. It's so hard. And I should say, wherever we're talking about the Red Shoes Award, I'm by no means a perfect listener, but it's something I really work on. And I hope others will find it as restorative as I have, as a kind of just the way I practice.
Yeah.
So,
well, I think half the battle is just the awareness around that and the intentionality behind putting in place moments to listen. And, Today's episode is brought to you by Seamless MD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what Seamless MD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. Seamless MD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on Seamless MD. Go to www.seamless.md. That's www.seamless.md to learn more.
A strange question about ambient.
Yeah.
So, some of the new ambient solutions, they not only listen and summarize, but they record the entire transcript, and you can even search back to see, did I actually say that? Or, where does the summarization, where's it sourced from in the actual transcript? And I'm curious if you've heard from clinicians maybe a change in what they say or do because they're thinking, oh, wait, now that this is being fully transcribed and recorded, maybe I want to be a bit more careful about what I'm saying because on the one hand, it may be great that everything's recorded, so you can point back to it and say, hey, no, I didn't say that thing that I was accused of. On the other hand, it's like, oh, wait, I did say this thing that I didn't think I said I should have said. Have you seen that change, like clinicians' practice in terms of like what they say or do if they have ambient turn on?
If they know that I think at least at our organization, it's still early for us, right? We actually have a couple tools that we're examining in parallel, and that has come up. It's come up before. Now, interestingly, it also came up back in 2020 when we all had this explosion of virtual care because different states have different laws about what you can record and not record. And I remember this so vividly on one of our early calls. The doctors were saying, "So what if a patient's recording me on their computer? I said, what if they're recording you now on their smartphone in their pocket and they didn't say anything? I think that people are, I think that's probably one of the big downsides that just kind of eats away at the joy of practicing medicine, is that it feels so litigious, like any encounter could become this. So I think you're right, knowing that there's an extra ear, an extra layer of, I hate to say it this way, but discoverable information. I'm glad to say most of my colleagues are not going to say anything in the room that they wouldn't feel completely comfortable getting, we always say, you didn't broadcasting abroad. Don't say anything that you are going to be embarrassed to see later. But in terms of pure privacy considerations and knowing where that data goes, I think people are not changing because it's recorded, but I think they are more cognizant that it's almost like, we always used to say, if you didn't write it down, it didn't happen, right? In the legal EHR. That's changed now. Like that has changed because it's not just the recording of what we each said, but it's that which the recording fuels. And at least in my organization, I think the physicians are, again, so eager for the potential here. They're willing to they're such incredible partners in helping us make sure that it stays true. And we're in a pretty highly supervised space with ambient, at least my organization is, in terms of joining the documentation or something that the ambient might pull out and suggest. And we've had not only the doctors super engaged, but the partners that we're working with are very much wanting to be, safety first in that forefront. I think the way a physician works has been changing a lot in the last 5 to 10 years in terms of what you say and your privacy. I was just hearing this in the news I can tolerate. The news is intense right now, and we have such a sway in the way that physicians' opinions are held. It's not like when I was a kid growing up and the doctor's word was a valuable influence, not just on me and just an individual patient, but in the community. That's all changed now, unfortunately, we don't really have any, we don't have any options. So the only thing we can do, it is change. The public opinion's changed. And so in some ways, knowing that it's recorded and knowing that the doctor knows this, I don't think that they're really changing that much. I think it might be giving our patient, if we do it well, I think it gives our patients trust that, I'm behind everything I just told you. And what's more important, it's even more important because now we've recorded it, and look, all the instructions I just gave you are now written down, so you don't have to try to remember it. And it's just what I said. There's an opportunity there, I think, to grow trust with both the patient, between the physician with the technology, but with the patient in that technology. So we'll have to see, though, right? Time and data will tell if we see a dramatic change. It's kind of like when open notes really became a thing, and we tried to study, did people dramatically change what they wrote? And I think most of the literature is, well, it depends who's bringing me the literature, but there's a lot of positive things that having that level of oversight actually improved the quality of what we had. So was that too optimistic? I've read too much about toxic optimism here now, but that's too optimistic. I don't know.
I mean, let's be fair. Healthcare could use a lot more optimism right now, so I'm all for it.
Oh, I love it. That's true. That's so true. We definitely have a deficit.
I mean, one of the things that bothers me about the media the last 5-10 years is it's so easy to have negative stories because it's clickbait. You get more views, and so healthcare has been unfortunately an easy punching bag lately. And not as many folks are talking about the amazing, inspirational things happening in healthcare, like new treatments, new therapies, lives saved, great patient healthcare stories. That's just not interesting anymore, unfortunately. Doesn't get the clicks.
Yep.
We have to change that somehow. Maybe that means healthcare systems have to continue going direct to the consumer in terms of news and stories and all that. So it's not all just, it's not all the cyber attacks on,
Oh, yeah. I mean, and it's interesting because there's a book called Humankind that was published years ago, but there's a new one that's coming out by the man who wrote The War on Empathy, and it's called Hope for Cynics. And I don't know if you've read it. I will verify the name here, but it's exactly what you're saying, is that if you look at again, this is so boring, but if you look at the data about human life and health and the ability we have to positively impact it, there's actually great news out there. But, and no offense to you or anyone listening, but if you watch literally the evening news, the United States NBC or CBS Evening News. Have you guys watched this recently? I think it might be a generational thing. It's not where I get my news personally, no judgment, but it's so alarmist. I can't watch it. Like the volume's so high even, and it's so alarmist that it almost shuts your brain down to seeing the evidence to the contrary. So I agree 100%. I'm not, I think I'm a cynic at this point, but I think if you are, again, back to the listening, if you are listening for those successes, if you are listening for the people working in healthcare to make things better, I mean, even in the last couple of years, we've seen things like Medicaid expansions and investment in things like maternal health. So sorry, pediatrician here. I'm always going to champion that maternal baby dyad and how we grow healthy adults. There's a lot there. And I agree 100%. The work you guys are doing here on your digital patient podcast and how we get the appropriate, narratives out there about that great promise and delivery on that promise, I think is important. And purely, I was watching the white coat ceremony for my health, and I was like, okay, we're going to be okay. Look, great people still want to go work in healthcare, even though it feels not always like that is in place for people. I'm greatly encouraged by that. So
it's such a great point. I mean, like when we look at how much like even just like human lifespan has grown over the last 100 years, or even just like I always tell people this, but like even like the last few years, like the pandemic was awful, obviously, but how quickly we mobilized, how quickly we put together treatments and the vaccines and technology allowed us to stay in contact through it all. I couldn't imagine 20 years ago how we would have survived this as a civilization. And it's incredible how much like humans have done.
I think that story about the mRNA vaccinations and how, I mean, how your various social medias will show you your photos. So it's April, which means it's the anniversary of terrible home haircuts and all kinds of other things that we all did in 2020, which was, I think, comic relief when I tried to give home haircuts. But somehow that the way that like people consume information, like how is that not the most inspiring story of bringing it and mobilizing it? As a pediatrician, like to have a effective, safe vaccine and have that. We studied vaccine hesitancy when I was in medical school, and now I've outed myself that it's over 20 years ago. And it was an outlier then. It was the exception. And now I think it is not. And now to the point about how our technologies have been leveraged, I think it's been an interesting path of how experienced clinicians, knowledgeable people, experts in their field, some of them have really used technology well. I mean, you almost have to brand yourself to get confidence in the message you're delivering. But I think we have to do that as the healthcare community. Otherwise, it's going to just get filled with noise. And it's just, people are not going to the same places they trended to get advice. Although I do think there's still people that trust their doctor to make their advice in their best interest, but there's just fewer of those relationships and connections. So you're right. It is remarkable and it's inspiring to see how we recovered from this. It's just part of what we do now. And I do hope maybe there'll be an incredible storyteller who seeks to tell these stories and gets them into the collective consciousness of our population, so that trust is built, restored, energized, grown. I think that'll be key. And I think the way it's not a one-to-one anymore. You can't go and hear your doctor. Like you said, I can't individually go tell, 1 million people why, but you can leverage the technology to trust that. And I think we've had some success with those things, but we're like so outmatched, right? Like the video your healthcare system sends you versus what someone is going to see on somewhere else. We're maybe a little outmatched there. So maybe that's another opportunity for people in this space to kind of think about, because we were even talking earlier today, the traditional patient education. I don't know if you all remember this. Remember pamphlets? Remember a rack of pamphlets? And that was the patient education. And I done a lot of work with the American Academy of Pediatrics, which I adore. It's my professional home. Advocacy, education, that is where pediatricians go. And they've had to evolve from like purveyors of pamphlets to purveyors of digital tools to communicate with patients and families. And I think that's probably still not quite as mature. You asked when we were talking earlier about where are the AI use cases, where's the low-hanging fruit? there's some good things around AI. I have kind of a Debbie Downer talk I give about the risks of AI. And there have been studies where they use it, people have tried to use it to produce patient-facing advice. So there was one where they fed a bunch of adult oncology protocols in. And then, of course, the paper reported on all of the hallucinations and arriving at the wrong conclusions and stuff like that, which is valuable. But could there be a role for write this and the translation step? That's still so untapped in AI. Like, who's going to be the first to kind of validate that there are safe medical translations? That most groups I know are using some kind of generative item with human oversight. Did this translate this right? Is this what this really means? And I think that could be a place where some of that distrust could be improved on if we thought of the way to do it. Probably not oncology chemotherapy protocols is maybe not the best trust building step with the generative AI, but it could really be used to say, okay, say this in plain language. What is compelling about getting your flu shot this year for this population, for this school system? Like, what should we tell them that's specific about their risk here in central Indiana, in Indianapolis, or in name it, the rural community? Why should they care? And then those generative tools can expedite more personalized messaging. That's very doable. And then, there's a momentum behind that. People are excited when you say, we're going to use AI. We're going to use AI to solve this problem. But what part of the problem you're solving is probably worth considering as well. So,
yeah.
Yes, it's like, don't use AI for the sake of saying you're using AI, and let's be very thoughtful and intentional about the problems that we're solving. Yeah. I love it.
It's like I've already referenced Jurassic Park, so at the risk of nerding
great
on
film,
you
by
as
the way.
well,
the new generation.
the original. Oh, I know, the original one from the original Michael Crichton text. But the other movie I'm going to reference is, now the one that was the first new Star Wars, where, spoiler alert, Han Solo was only in that very episode 8, I think. I don't remember.
Yeah.
When they're going to attack the Starkiller base, the Force Awakens.
Yes, yeah.
At one point, they're going to attack the Starkiller base, and one of the characters says to Han Solo, "I know, we'll use the Force." And Han Solo says, "That's not how the Force works." Any chance I have to reference that, I'm like, that is to me kind of AI. People are like, "I know, we'll use AI," and I'm like, that's not how AI works, or it might actually make your problem worse. I'm not really sure you want that. But we don't want to waste that energy people have behind it. And if you start to peel the onion, like, we have AI, we might not be a generative language model, but we've got a lot of AI that we probably even weren't thinking about embedded in different parts of our health infrastructure.
Or they just want something simple automated.
Yes. Yeah. And I'm like, sure, it's in the most broad sense, is automating this AI, well, is it going to get you better adoption? Again, it's a little bit about marketing when you work in this space between those two worlds. It's like selling the excitement behind it and kind of saying this could really, people are hungry for that. They're hungry for something that's going to help make our patients' lives better and make the everyday go a little bit more smoothly. So, I'll have to think on that one about how I can spin there's a lot embedded in your email. Your email prompts you now with thoughtful suggestions. Yeah. That's AI. They're like, that's not the AI I want. I want the cool AI that's gonna,
You telling me that the staff at IU aren't excited about Copilot? Really?
I love. So I will own that. At this point, I'm probably too dependent because I kind of just expect it to know. I'm like, show me that thing we were working on the last time that we were talking, and it will do that, right? I'm like, that's pretty good for me. But you're right, I might be spinning that a little more fun. I may find a little more joy in that than
I think Microsoft would love to do a case study with you.
I can be like, look at that. It is interesting because in the if you're doing peer review for journals in the literature as well, that's the same space. That actually is an interesting use case, I think, as well. A lot of journals have been like, you can't use these engines, and yet in the literature we want it all to sound like it's written by in the same language, same Kate, at least in English language medical journals, there's just this expectation, and I'm like, okay.
Wait, so have certain journals banned the use of like generative AI for writing manuscripts?
I think there's like disclaimers on several of them that you cannot. I've even seen it listed as like you cannot list a generative AI engine as your co-author.
That's
like you, and I think a lot of them have woven it into sort of their plagiarism statements about the expectation. But it's a very gray area. I think like if you're writing a letter for someone if you're writing a letter of recommendation, that's another use case that I've heard people say, oh, they are supposed to sound kind of similar. And so if the difference is I can't have time to write for someone at all versus using it, I'm like, oh, don't make me choose. I don't want that to be the use case. That sounds like it's, hurting a student.
I mean, but, just like with ambient, you have to sign off on the
I have to sign off on the final one. Exactly. Right. That was the argument we made too. It's like, well, it's how you get there, So I think we at least, I'll just say, on behalf of my organization, are constantly updating and evaluating those recommended policies and practices to try to really give people a chance to get value. And then you have to kind of trust each other too, to be like, okay, first do no harm, like don't put anything into an engine you can't see and you can't predict that we don't have an agreement with, which again, back to governance and oversight, those are never glamorous topics. People don't give you sparkly statuettes for being super amazing at governance adherence, right? Although I would argue that is how change happens, is just keeping at it. It's not even the garage stories, right? The garage unicorn breakthrough stories, like there is that, and it's a great idea, but cultivating, growing, redoing, plowing stuff up and reseeding your garden, like, these are the things that I think really do generate meaningful change, and it takes time and it takes a lot of people. Ellen, you mentioned this great recognition that HIMSS does around the change makers, which I'm so honored to be in this group. But if you look, there's a trend. Almost every person references the myriad of teams that contributed to the change they got to help be part of. And that's true here too. Like that's any of these considerations, the governance and oversight of it requires a complete effort. And I guess I'd always be a little leery of someone coming to promise all the things and they alone can deliver it as the individual. That's not evidence-based or data-based. That's just me I think a lot of us would kind of be a little leery. Like, really? You personally built this and you changed all these things. I think that's probably a good tell to always be a little skeptical and ask questions, right? Stay curious about how someone affected the change they did. So that's my cynicism showing a little.
No, it's good. It's honest, and it's certainly a team effort when it comes to digital transformation. But Alan, we should probably talk to HIMSS about setting up a HIMSS governance award to recognize.
That's right. Yeah. I love it. I'd like to thank the Academy for consistent expectations and discipline and teamwork. I mean, that's what governance really is.
I love it.
Now I feel bad if there might be science council already committed to this that I just wasn't aware of, but I think that would be phenomenal.
We might have to make it a cooler name though for the award to get more folks excited about it. But
well, I had a mentor who always talked about the fact that gardening is not a glamorous hobby. Weeding, watering, waiting for things to grow is not always the most glamorous. So maybe we need to rebrand that. Yeah, we got to come up with a cool name around governance and cultivating long-lasting change. I don't know what that name is, but we can.
Yeah.
Hold on.
We'll run that prompt through ChatGPT and we'll get like 10 variations of word names.
I love it. Create a title for an inspiring governance recognition. It should recognize the sometimes unrewarding plodding efforts of trying and building trust over a long period of time.
I bet you would have actually some really good ideas. I bet
it would too. It would too. Now, formally, I would of course never do that. And as we're here,
of course not.
I would never done that. Never done that in the course of a conversation. Now I'm really curious though. So
I love it. Yeah, the first one that would come up is the Debbie Downer Award for Skepticism.
Yeah,
we got it. That's great. So Emily, I just being mindful of your time. We could talk to you for another probably 4 hours and never run out of questions to ask and topics to talk about. But being mindful of your time, we're going to flip over to the Fast 5 lightning round. So this is 5 questions to get to know you better for our audience. The first question we have is, what is your favorite book or book you've gifted the most?
Okay. That's a really hard one for a lifelong book reader. I know it's supposed to be lightning round, so I picked one from childhood. Yeah. My childhood book is Anne of Green Gables, The Eternal Optimist, classic book. And then the one that I've given a lot in my clinical work and my work life has been Weapons of Math Destruction, MATH. It's starting to get old now, but it's a really cool intro, again, in my Debbie Downer spirit of like, be aware of the power of large algorithms. So those are 2 that I love to gift and return to.
Nice. Love it. Question 2, who is a person either dead or alive who you'd love to meet?
Okay, so this is a little unfair asking it the week that Taylor is releasing her new album on Friday when we're recording this, because this is so unfair because I'm going to answer 2, because I'm a big Swiftie and I'm very excited for the Tortured Poets department on Friday. But I do also think I would love to meet my grandfather, who's a 100-year Hoosier farmer here in Indiana, and just get his perspective on what it was like to start a life in that time and setting, and share kind of the perspective. Actually, both my grandfathers, my other grandfathers grew up and died in China during World War II. So I think I'd love to meet both of them.
Yeah, fantastic. Question 3 is a bit different. Would you rather have super strength, super speed, or the ability to read people's minds?
Oh, I think I should probably say the real ability to read people's minds. I think that would be the epitome of what I seek to achieve as being a good listener. If I could, although that's a double-edged sword, right?
Yeah,
that'd be kind of frightening too, but totally worth it.
I also wonder if it would maybe compromise your listening a little bit, because you would maybe jump to conclusions. You feel like you don't need to listen anymore. You can just read the thoughts.
It would. See, these are very weighty. These can't be lightning round questions. They're deep, soul-searching questions.
I love that.
Well, you should be constantly telling people, I know that's what you said, but I don't think that's what you think.
Is that what you meant? I'd have to go watch a lot of movies about empaths and science fiction movies about how they manage that input and how they work.
Question 4, what is something in healthcare you believe that others might find insane?
I think I thought about this one for a while, because I'm like, well, sometimes you don't really want to know how the sausage gets made in healthcare, and it can be kind of horrifying. But you know what I think they might find both insane and inspiring is how much of the excellence in healthcare relies on the incredible people delivering their care. How frequently there are miracles and just the incredible kindness and connection that people that practice medicine, and that's the entire team. I think once they've lived it, that's what people consistently say. They may not remember the most articulate precision medicine, CAR-T description, whatever incredible thing that happened. They will remember how the team worked together and how they made things happen for them as a patient. Like, that is just the thing that I don't think people realize how much of it depends on the individual nature of people that work in our field. So they probably think it's insane.
Totally true. Yeah. So the last question that I had, I think we already know the answer, but I was wondering, on a scale from 1 to 10, how excited are you for Friday when the Tortured Poets department is released?
Oh my goodness, I'm an 11. I'm so excited. I realize I referenced Taylor earlier in our discussion, because you are right, but I'm so excited. I think that we might have some tired people on Friday, just as a warning, because it's going to probably come, at midnight, and you got to listen to the whole thing, listen for your Easter eggs, and then discuss at length. So I'm thrilled. I can't wait. So
I love that. Well, that's awesome. Emily, thank you so much for joining today. You've shared just so much wisdom with us. And like I said earlier, we could talk to you for another 4 or 5 hours and never run out of things to discuss. That is unfortunately a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at SeamlessMD. If you like the podcast, you want to learn more, visit www.seamless.md. Emily, Dr. Weber, again, thank you so much for spending some time with us and really just contributing so much to the conversation for our listeners to hear about. So thanks so much.
Thank you. Thanks for all you guys do in bringing these conversations forward. A longtime listener, super, super big fan now to get to be part of it. Thank you.